On the Scene video coverage of ESC 2012 is supported by Pradaxa.
Well, it's day 3 here at the ESC 2012, and I'm on the scene. It's Chris Cannon. I'm joined by Dr. Fred Beauvais, the editor for Accel. We have a lot of big trials here. I think headlining today was the FAME2 trial that looked at the use of FFR during cath in patients with stable angina to see whether that could help guide PCI. So this was a study of several hundred patients looking at a strategy of FFR-guided PCI with optimal medical therapy versus optimal medical therapy alone, and found a benefit of the FFR-guided PCI strategy. There was a difference of about 10 to 15% fewer patients requiring urgent revascularization over 1 year follow-up in the FFR-guided PCI strategy. Now, this seems to go a little against what we think of in COURAGE of optimal medical therapy alone, was consistent with equal numbers for death or MI, but I think an intriguing strategy that could help guide PCI. Fred, what do you think of this study?
Well, I think it does help us in patient management. You know, when we see an intermediate lesion on the angiogram, we're never quite sure what's going to happen to that patient, and FFR tells us whether it's significant or not. The data from FAME2 is suggesting that we can predict that about 1 in 5 of those people with a positive FFR is going to get in trouble within a year, either having a revascularization or possibly a more serious event. And so it gives us an opportunity to predict, at least statistically, what the likelihood of outcome is going to be. In COURAGE, I think the message we got was most of these patients are stable, and if they destabilize, we're going to go back and intervene. Here, we can at least get some idea to predict who's going to do it, but again, it's going to be 1 in 5 of the people with a positive FFR.
Very true, and this won't mean that everyone has to have FFR and have the guided strategy, but I think we'll open the door to using this in the cath lab to help guide, as you say, in those intermediate lesions. Now, another somewhat related thing now moves to a non-invasive approach, and this was the CORE320 study that looked at adding perfusion assessment on a CT angiogram and compared that to the gold standards that we have of either cath with FFR or a stress MIBI to see what are the flow-limiting lesions. And they found very good and improved prediction of a flow-limiting lesion when adding the CT perfusion. Now, Fred, one of your early papers was looking at CT angiography, and what did you think of this paper?
Well, I think the data from CT angiography has perfusion information in it. It has anatomic information in the coronary vessels, but at the same time, that contrast material is flowing through the myocardium. There's a traditional background of mathematical analysis of density changes of contrast in the myocardium that assesses perfusion. So what the investigators did here is added the anatomic data to the perfusion data and found that yes, you get better accuracy in prediction. This is like taking a perfusion scan and a cath and combining those two together. What I think they pointed out with this high resolution CT is that you can get all this from one data set.
Well, it's a nice thing to see the CT angiogram, much maligned in some of the primary prevention settings, but here a very useful and adjunctive anatomy and physiology assessment. I think a final thing was a look at the consequences of the earthquake in Japan, a study finding an increase, not that surprisingly, of sudden death, myocardial infarction. Also, heart failure and pulmonary embolism were also seen to be increased in the consequences following that earthquake. Is something that's been seen before, I think, in other studies.
Well, we've seen data published from the California earthquake, which basically imparted the same concept that when a sudden event that occurs like this, a lot of people that have stable or asymptomatic underlying disease suddenly get symptomatic, and I think one can understand why. There's a tremendous amount of stress from this kind of an event. People become homeless. People are rattled by the actual vibrations of the earthquake. All of these things can provoke the progression of a underlying stable disease state into an active event.
Yeah. Well, stay tuned. There are several other trials that we'll cover from day 3 at the ESC 2012.